And from Providence Mission Hospital, we want to welcome Dr. Ehab Olamari to our program. Thank you so much for joining us, Doctor.
Thank you for having me.
And we talked a little bit about what arterial valve stenosis is. That's kind of your specialty. The heart is your specialty, but most people haven't heard of this stenosis in the aortic valve, right?
That is correct, yes. So to start with, aortic valve is one of 4 valves in the heart that allows the blood to go through different chambers. The aortic valve is the main door of the heart that allows the blood to come from the heart to our body.
Okay.
That's the oxygenated blood. So basically, we have here the left ventricle, which is the left lower chamber, and that is through the aortic valve allows the blood to go through the aorta, and from the aorta it goes to our body.
Okay.
Now, this valve has 3 leaflets, and during our lifetime, it opens and closes about billions of times.
Okay, yeah. Every time our heart beats, basically,
exactly.
Right?
So it's, it's a lot of times that it opens and closes. And it allows the blood, again, to go through that valve, which is a one-way valve, so it should not come back. But with time, what happens is there will be wear and tear on the valve. There will be some deposits of cholesterol and calcium. And what happens is that valve becomes restricted. These leaflets become restricted. And the valve it does not open fully with time.
Okay.
So ideally or normally the valve opening should be about 2 to 3 centimeter opening. But when it becomes tight with all that calcium in it, it becomes less than a centimeter opening.
Okay. And obviously that would restrict blood flow, right?
Exactly. So that will restrict the blood flow, and that requires the heart to work harder. And this is when the heart will be kind of working a lot, more than what it should be. And patients will start having symptoms, and then they could actually, eventually, the heart could fail.
Okay. What are some of the symptoms, like fatigue and things like that? Or?
So symptoms are wide. There's a wide spectrum of symptoms, but the most common symptoms are shortness of breath with exertion, decreased exercise tolerance, chest pain, fatigue, passing out, or syncope. The problem is this is the valve stenosis is it's an age-related problem most of the time.
Okay.
So, and it's a lot of times it's missed by the patient because they think that these symptoms are just normal aging process.
That's what I was going to ask. It's hard to pinpoint it because of the fact you'd think, oh, I'm just getting older. I'm just not as vibrant as I used to be.
Correct. And unfortunately, actually, we've seen many patients that they have this problem. They were not diagnosed or underdiagnosed just because they think that these symptoms are just normal process and it's a normal aging. It's normal to get tired. It's normal to get short of breath and so on. But then once we diagnose the problem and fix it, they feel the opposite.
Okay. And so we understand that. So what is the prognosis in terms of stages? And if I have this and I don't get it treated, could I die from this? Is that extreme?
So if you have severe aortic valve stenosis, so it's very tight, and you are symptomatic, you're having symptoms, this prognosis is worse than metastatic cancer.
Oh my gosh.
Meaning, if you don't get it treated, patients will not make it. Most of them, 50% of them or more, actually, they will not make it for 2 years.
Okay.
But if you get treated, you go back to your life expectancy, go back to your normal age population, basically matched for their peers' age. And that's where it's very important to diagnose this problem early on and get it treated.
Now, you said sometimes it's cholesterol related and those kinds of things. So are people who are on cholesterol blockers, can that help with the process of stop this from happening in the first place?
I will say, yeah, it helps actually reducing or slowing the progression of the problem. Again, this is a problem that we see a lot, especially in the age of above 70 and 80 years old. It's a normal aging process. There is a wear and tear on the valve. But having the patient control their blood pressure, control their cholesterol, it is important to slow the process.
Okay.
Instead of you can't 100% prevent it, but at least you can slow the process.
So is this something that's just going to happen to everybody, or is it just certain, sometimes it hurts some people and sometimes it doesn't hit other people?
It actually does not happen to everyone, no.
Okay.
It depends on your, of course, your genes, your lifestyle, what did you do in the last 7 years, correct? In terms of your cholesterol, high blood pressure, and all these things. But also there are genetic components or there are congenital problems. Like some patients, you see this valve has 3 leaflets, correct? Some patients, they were born with 2 leaflets that we call bicuspid valve. And those patients, the pressure on the valve will be on 2 leaflets rather than 3, so the wear and tear will be faster.
Okay.
These patients they'll present with tight valve early on in their 50s and 60 years old rather than in their 70s and 80s. So there are multiple factors that could lead to this, but the main one is the age-related aortic valve stenosis.
Okay. So treatments, is it a valve replacement? Are you somehow just removing the stuff? What do you do to treat this kind of thing?
So we have 2 ways of treating this. The traditional way is by open heart surgery. Basically, when the surgeon go in, open the chest, take the old valve, and then replace it and place a new one.
Okay.
And for the last 10 plus years, we have actually a new technique that is the minimal invasive technique that is called TAVR. TAVR stands for transcatheter aortic valve replacement.
Okay, now we have a video of this, right? That we
Correct.
can take maybe a quick look at. You maybe walk us through what this looks like and what's going on in this video.
So basically, this is a minimal invasive technique that we don't have to open the chest. We go through the groin through a small catheter and small incision, and we will have a valve on that catheter that we're going to deploy in the old aortic valve. We don't take the old valve out. What we do actually is we place this new valve inside the old valve. Here we're just doing some reconstruction of the valve inside the body to make sure that the balloon is mounted on the stent, or the stent is mounted in the balloon. And then we go around the aorta, and we're looking, obviously, this is through an X-ray or basically fluoroscopy in the cath lab. Now, once that valve, the new valve is across, then we make some fine adjustments to make sure that the deployment is in the right place. Now, before we deploy, we have to pace the heart very fast to prevent movement while deployment, because we want the heart to be still, basically, when we are deploying. So now the heart is beginning paced about 180 beats per minute. Then we deploy the valve. That takes about between 5 to 10 seconds. And then off the pacer, we take everything out. And now you have a new valve inside that old valve.
Okay.
The old valve has all that calcium around it. And basically, when we open the new valve, we smush the old valve to the side. All that calcium on the side is going to be used as a cement to hold the new valve.
There we go.
Yes. So it's a natural cement that will hold the new valve in place. And now you have a new valve that should last you like another 12 to 15 years.
So you don't stop the heart to do that, but you put it in kind of an arrhythmia, a really fast beat, so it's almost as still because it's just almost vibrating instead of doing a regular beat, right?
Exactly.
Okay.
And the whole, again, process is about like 10 seconds.
Okay. Now the stent that goes in, like I was going to ask, because it is a closing, stenosis is a closing of the whole area, so that stent, it opens everything up and keeps it open for the rest of the life of the patient, right?
Yes. Well, so the
is that example of it?
That is an example of it, exactly. So this is basically the stent around is a cobalt chromium. The valve itself is a cow material, like a cow valve, material, and then we have the fabric to prevent like any leakage around the valve. And these valves ideally last between 10 to 15 years. And if the patient in the future needs another valve, then you can do the same technique inside this valve.
Okay, so there we go. Wow, that's amazing. So what should the patient feel if they go through this process? They've had this. How should they feel at the end? Are they up on their feet that day, or is it are we good to go, or is there a rehab associated with it?
So we send everyone to rehab. 3 months of cardiac rehab after, but most of the patient, they will feel the relief, I will say, in their symptoms almost immediately or on the next morning. A lot of patients, obviously, they have other problems, like other comorbidities, but they feel great after performing the cardiac rehab because now you open that valve and the patient can breathe and the blood is flowing freely.
Terrific. It's amazing. And over at Providence, you guys are doing these pretty regularly?
Correct.
Is it something that just happens? And
yes.
And you guys have all the diagnosis, so if people go in there, if they're having these kind of challenges, having issues, feeling this fatigue, feeling this dizziness, fainting, you guys should be the ones to tell them what's going on.
Yes, I think it's important, for any patients, they can't diagnose themselves, and it's very important if any patient has new symptoms, just don't blame the age on these symptoms. Go to your doctor, get it checked. Right. And these procedures are easy, they're life-saving. Recovery is fast. You know, these patients, they go home the next morning, they walk the same day, they go home the next morning, and we do this under even moderate sedation. It's not even like a full sedation. So it's a fast recovery. Patient feels great, usually, you know, almost immediately or the next, you know, few weeks, and it saves a life.
Amazing. From Providence Mission Hospital, Dr. Ihab Olamari, thank you so much for joining us. Amazing stuff.
Thank you very much. Thank you for having me.
We'll be right back with the Publishing Club. Stay with us.